So today we're going to discuss why is it we're going to move from the PCMH model to the advanced primary care model. There are several key points. First of all, fee-for-service compensation was commonly used in the PCMH trials that have been done in the past 10 to 15 years, and this has had adverse incentives towards population health and creating a high-value care environment. That framework alone does not actually add all the key elements of high-value care that we want to see in advanced primary care. So we're going to be discussing how it is that we can actually move from this model to the advanced primary care model. The PCMH was built on a chassis fee-for-service in many countries. Both the United States, Canada, and Norway are examples where primary care systems are paid on a fee-for-service model, trying to deliver on a population health basis, which has not worked very well. The new focus is on team-based care, but compensation to clinicians alone tied to volumes does not really drive team-based care development, nor does it actually drive the metrics that we care about in population health. There is little focus on proactive care in risk populations. The PCMH model showed very mixed results as a result, and many failures of the PCMH model occurred due to the fee-for-service infrastructure that was supporting it. So how does fee-for-service impact our practice? It creates a model of survival by throughput where total visits are actually the measure. Doing things to patients like procedures, labs, radiology improves reimbursement, and only face-to-face encounters counted until recently during the pandemic when we started to allow virtual visits, but only video visits counted and not telephone visits. Outcomes really do not matter for payment, and there's really no sense of responsibility for caring for the patient outside the office visit. So what happens with these rapid office visits? Typically in a fee-for-service environment, you may see 20 to 25 patients a day, and face-to-face time between the physicians and the patients is only about 8 to 10 minutes. There have been numerous studies showing that the longer the amount of time spent with the patient, the more likely the accurate diagnosis will be reached. And short visits actually lead to more inaccuracies and more tests and more referrals. And then came COVID-19. This pandemic really exposed the weaknesses of the fee-for-service model as many practices suffered greatly trying to stay open in an environment where you could not see patients face to face. This led to some bankruptcies of practices and certainly put a strain on the system as a whole, whereas direct primary care practices or practices that had capitation model payments, those practices did fine because they could take care of people over the phone or virtually without any decrement in their income. So how do we address the problem of the PCMH and the fee-for-service model in the United States? There are several organizations that got together to work on this problem. The first was Family Medicine for America's Health. Then they combined efforts with the Patient-Centered Primary Care Collaborative and also worked with the National Alliance on trying to redefine what primary care should look like in an advanced primary care model. Part of the work of Family Medicine for America's Health was also to define the scope of practice for family medicine physicians and the team-based care that we needed to provide as a unit, working together to provide health for all of our patients in our population. So how does advanced primary care differ from the PCMH? It really takes on the attributes of the PCMH, but adds in it key aspects of high levels of access, team integration, and population health principles to create better effectiveness. So with the advanced primary care model, we look at having advanced access, team-based care, proactive prevention, care coordination and integration, robust whole person scope of care, chronic disease management, population health, all of this supported by a population-based payment with value-based incentives. So again, as we talked about in an earlier video, why does payment have to change? Is that if you're paid on a population-based model, on a per member per month payment, whether it's for the full capitation risk or just for primary care capitation, this allows you to change the way you take care of your patients and allows for alternative visits such as email, messaging, or portal visits, or phone visits. Patient experience really does matter. If you have poor service in your clinic, patients are going to move to a different clinic. If you have high value care being delivered, patients are going to stick around because they will want to receive the care that you're delivering. Outcomes do matter in population-based payment because you can incentivize better outcomes and care gap closure and risk management in those population-based incentives. Another advantage of population-based payment is it allows you to adjust your appointment length based on the needs of the patient and their risk. We will be talking next about the high value visit model. We think this is a key component to delivering high value care to patients, especially those who are high risk and need to establish a trusting relationship with their primary care clinical team.